the choice of TKI is getting complicated, and especially when you add the level of immuno-oncology drug and the different PD-1 and PD-L1 inhibitor. But actually, the data, what does the data tell us? In 2013, there was a large phase 3 trial, a non-inferiority trial of pazopanib versus sunitinib, both very similar VEGF receptor inhibitor. That showed that pazopanib was not inferior in terms of activity compared to sunitinib. But in general, if you look at several quality of life domains, the drug is better tolerated. So, this drug has been a preferred drug in many settings in the community. And then came cabozantinib, which, still was not compared to pazopanib, was compared to sunitinib in the frontline setting, and showed superiority, though in a small trial, but with very intriguing activity in bone metastases in patients that were intermediate and poor risk. So the frontline, space is complicated. Pazopanib seems to be as active or not inferior to sunitinib. Also numerically, the numbers were a bit higher with sunitinib, but it's not inferior if you look at the whole trial, the statistical consideration, but usually better tolerated. And you have a drug that is very active in the second-line setting, the front-line setting. That seems to be better than sunitinib, at least with response rate and progression-free survival. I still think that, the future is, combination. And while sunitinib and pazopanib were not being able to be combined with a checkpoint blocker, pembrolizumab or nivolumab, due to excess toxicity, cabozantinib so far at a lower dose of 40 milligram a day was able to be, combined with nivolumab in a study at the NCI, and hopefully, and this regimen actually is progressing the cabozantinib nivolumab toward a phase 3 trial.